Thank you everyone for joining us in person here and as well as anyone who's streaming online. I'm so excited to be here today. Thank you for the introduction. I know the last name is a tongue twister. And so, we, Dr. Lawrence and I got to talking yesterday after the things that we had seen and heard and the people that we have met over the last couple days. We kind of decided that we were going to do a little bit of improv up here, so I'm sorry to my team. The topic of our conversation today was originally leveraging DPC to care for the underserved. And we are still going to be talking about that. But we're also going to layer in a little bit more of the idea that health equity is something that should be an integral part of the DPC equation. And so we're going to spend a little bit more time on that towards the end, and hopefully there will be some time for questions and answers. And I think to kind of set the context and set the stage for everyone who's here today, I wanted to do a little bit of background information of why are we here talking to you all about health equity, especially me. I'm the tech person at Hint, right? And so maybe we can start with Dr. Lawrence, your journey into DPC and the background behind why health equity is so important to you.
Absolutely. Thank you all for having me. My journey it kind of starts with my journey into medicine. I'm a second-generation physician, and so I always knew I wanted to be a doctor since the age of 6. By the time I got into undergrad and I started getting active into social justice and joining a couple of organizations on campus and doing marches and talking about the inequalities, as well as minoring in sociology in undergrad. If you asked me what else I would do if I wasn't a doctor, I would be a social activist. But obviously, medicine was primary. And then through the course of the rest of my journey, it became, how do I interweave everything that is valuable to me into the career that I want it to be? And so in training, I met one of my mentors who introduced me to the concept of health inequity and healthcare disparities. And the light bulb went off as to, that's how I can bridge the gap between social activism and healthcare injustices into medicine. And so that's kind of how I've gotten here today.
Thank you so much for sharing. For me, I am the Senior Director of Engineering at Hint Health. And so it seems a little bit strange for me to be on the stage maybe, but to give you all a little bit of background, I have spent over 17 years in the tech space and have almost always, in some form or another, been either the first or the only of something on my team. So the first or the only Southeast Asian person on the team, the first or the only woman on the team, the first or the only mother on my teams. And so the concept of diversity and inclusion and welcoming and belonging is something that's very core to my experience through tech. And last year, I had an experience actually with the US healthcare system that was unexpected. I unexpectedly became the full-time primary caregiver for a family member. And so I was a medical advocate and legally a medical representative for this person in my family. And as someone who has been primarily healthy through my life and relatively young, I knew our system was flawed, but not to the extent that I got to experience it as a caretaker and as an advocate for my family member. And here at this summit, as we're talking about compassion and care and human-centric focus and relationships, it's not only that I was caring for a geriatric disabled person, but the dignity that was stripped away from her, right, through that process. And so I'll try not to get too emotional, but that's why I'm here at Hint, and that's why I am now blending my role and sort of my experiences as someone who has been minoritized, right, with my experiences in the healthcare system, and really just being able to be here on stage is like such an honor. So thank you for being here with me today.
Absolutely, and thank you for sharing that a little bit more about that story, because I find a lot of parallels in my own story about being the first in spaces, and just kind of like looking at the last lineup. I was like, oh, there's 3 black male physicians, one after the other. That's amazing, because
Absolutely. We have brought the melanin to the stage today, and I'm happy to see it.
and so, that's an anomaly, though. I want you to realize that, right? So there are about a million over, a little about 1,077,000 physicians, about 844,000 practicing physicians. Black physicians make up only 5% of the physician population. Black male physicians make up 2.6%. So when you see, 3 black male physicians on stage, don't think that that is normal. That's by far not normal when black people make up 13% of the population, right? So you're seeing this huge gap in the representation from the people that we take care of and we see in our communities versus the people who are actually in a position of privilege and power to be able to take care of people who don't necessarily look like them, who are in vulnerable positions, and who face challenges that we may or may not relate to in some instances. So.
Yeah, and that's a perfect segue, because we can talk a little bit then about what it means to be underserved in healthcare and what healthcare inequities actually, what the impacts of that are, what are the outcomes of that, right? And so one of the things I wanted to also level set on for this crowd today is around the barriers to accessing healthcare. Yesterday we heard from the specialty care panel about how everyone has issues accessing and utilizing the healthcare system as it is traditionally and currently. And so there are these structural and systemic reasons and barriers for not being able to access healthcare, right, that are related to race, gender expression, age, for example, that I had to witness, right, firsthand, socioeconomic status, disability, weights, all of those things. But there are also the barriers that we've been talking about over the last couple of days, too, that are maybe not structural or systemic, and like the examples of that are things like small business owners who struggle to access healthcare, people who live in rural areas. We heard from Big Trees MD yesterday about that as well. And so I think regardless of the barriers, it's a problem that I think this group is particularly well positioned to help address. And so I want to spend a little bit of time talking about the actual outcomes, right? The current state of the world right now, these disparities in our healthcare system, what outcomes have you seen, right? What's like the data behind people who can't access healthcare? What happens to them?
Got it. So based on the commentary that I heard yesterday, I would kind of want to make a point. I think it's always helpful to have framing before you get information so you know where we're going and why we're going there. And so we're going to talk a little bit globally about kind of healthcare, disparities and equities, what some of the studies show, particularly for, minoritized BIPOC populations, Black, Indigenous, people of color. My particular persuasion, obviously, is African American, but then also leveraging the data to show how you can take your own approach to health equity. Because I think it's important to understand that we each have a role to play, and it doesn't all look the same. It doesn't all look the same, but it is all equally important. So, for me at Harvest Health MD, one of the main approaches we have, or main populations we want to serve is Black males. Why? Well, I'm a Black male, if you couldn't tell. And when you look at health outcomes, we suffer the worst from chronic diseases. We live about 4 years less than every other group, that's race and gender included. Average living to about 66. We have less access to healthcare as well as insurability. And so when you look at these things, it's obvious to why black men will have worse outcomes. And so it's one of my goals to change that, both from the outside and from the inside, looking at, how I can educate individuals on how they can take better control of their health, but also what can I do from a community aspect that helps people rally around the fact that health is important, and sometimes we take it for granted, but it's not until you're ill with something that you realize how important it is for your survival and for your vitality.
Absolutely. And some other statistics here, things like black infants being more than twice as likely to die as white infants, right? Black women also suffering much higher rates of mortality from pregnancy-related causes. And all of these outcomes are it's heartbreaking, right? But then also, the thing that really strikes me is that these outcomes are reinforced through these negative feedback cycles in the current healthcare system, right? Because we have populations that have not received good healthcare and thus don't trust the healthcare system. And so they don't have normal or usual sources of care. They don't seek out healthcare perhaps when others may. They delay seeking out healthcare because they just haven't had those good experiences. And so these cycles feed on themselves, and it creates worse outcome after worse outcome after worse outcome, right? And so it's these conversations that we're having here about DPC are what give me a lot of hope. And so segueing then into sort of our next topic, I wanted to hear more about Harvest Health and how have you structured your practice to build that trust with the community that you're trying to serve, and what sort of things are you doing to really reach your audience, similar to how we heard Dr. Jasper earlier describing his practice.
So when I was thinking about some points for the talk, in my mind, I renamed the talk. I was like, we're going to make it a little bit more about us personally,
Yes.
And what we can do, right? So make health equity part of your equation. How can we make equity part of the equation, right? And it starts with understanding that it is an issue, first of all. Like, if you don't acknowledge it, then we're not starting from anywhere. But understanding the issue, looking at the data, seeing what the data says, and then seeing how we can locally do our part to address those issues. And so at Harvest Health MD, like I told you, we have a focus on black males. Why? There was a recent study, and when I'm referencing studies, these are usually AAMC. They're JAMA articles and things of that nature for the physicians in a group that showed that if you increased black physicians by 10% in a county, black patients live longer, like 31 days longer. It's like, wow, that's interesting. Okay. So I did the math, right? Because I said make it personal. So I look at Savannah's population. It's 52% majority black city. Okay, it's about 45,000 people in the city. Okay, well, there's maybe about 20 to 30 black physicians. If we increased, that number by 4 to 5, we can effectively increase life years by 6,500 years of life in the community.
And right now, you're the one and only black male-owned DPC in Savannah. Is that correct?
That is correct.
Well, this is your call to move to Savannah and open some DPCs. You got to help some black folks live longer. So yes. So then, going into some specifics, then, right? Of like how do you run your practice differently?
So I think the first thing is again, framing, right? So let's think about it, all right? Particularly in the academic setting, you think health equity looks like just, taking Medicaid patients or having an uninsured clinic. But in DPC, it's no secret that we take memberships and we ask people to pay us for our services, right? And so then it becomes, how does health equity fit into that picture? And what I found is that you have to be a lot more creative than you initially were, and that's okay. Right? Start thinking outside the box and stop looking at the traditional aspects. The traditional aspect is you get in medicine and, maybe you're on a diversity committee and maybe you're on the admissions team. Okay, well, I don't actually want to do that because I realized that my predecessors do that for about 5 to 7 years and they either get pushed out or they're burnt out and they end up leaving administration and doing something else. And so when you start leveraging DPC, particularly from my journey, it was, okay, well, I don't want to practice in that model because I don't necessarily agree with the outcomes of that model, so let me look at direct primary care. Now that I'm in this new space where I'm asking people who sometimes may or may not have the funds, how do I get creative about my take on health equity? Okay, so one example would be we created the Black Doctors List in Savannah, Georgia. By we, I mean I combed the internet for hours and tried to find all my colleagues because I was by myself. And so I had to find mentors and I had to know who was in the hospitals and who I would refer to. And, as a physician, if I can't find the people in my area, how much more can the patients not find the people that they're looking for or the people that can potentially help them live longer? And so put that together, put it out, and I put my own money behind it. Last month or 2 months ago, spent $500 on Facebook ads to run the Black Doctors List. Thousands of comments, hundreds of likes. Oh, wow. WTOC, the local news station, picks up the story, brings me on the news. Even more exposure. Triple win. Now you're looking at DPC. Well, attached to my list is an opt-in so people can learn about DPC. All right, so that's one. Attached to the list is a list of all the Black physicians, so patients who that is particularly important to them, they have the option. And then also, I'm the president of the local Minority Medical Society. One of my goals on that arm was to increase Black physician visibility. So I hit all three of those things in a different way, looking at health equity and how I could best serve the community, serve my colleagues and getting them more exposure, as well as serving DPC and letting people know that, through this practice, we have a doctor that's doing a different model and has equity built into it. So it takes a little bit of intentionality, thinking about the needs of your community, where the gaps are, and leveraging those things based on your personal experiences and what you have a personal affinity to, right? And so kind of going a little bit more into that, when I say health equity looks different, 3 points I want you to take away from that aspect: leverage data and the studies. I gave you a couple of studies. Some more is that we find that Black patients live longer when they have Black physicians. We find that they're more likely to be okay with or accept screening and prevention, right? And these things are not just, if I'm Black, I can't help. This country has a steep history of medical distrust and taking advantage of vulnerable populations. And, it's only in 1972 that the Tuskegee experiment, if you've heard about that, it's only 1972. So if you were born before 1972, you are eerily familiar that, okay, in my lifetime, there have been people that have been affected by medical racism, lack of consent, and just being taken advantage of in the medical system. So understanding that where this mistrust comes from, where this avoidance comes from, and addressing it head on is a main issue and something that needs to be looked at when you're approaching health equity in your individual communities. So leveraging the data, looking at your personal experiences, where do you fit in the picture, and then also assessing your community needs, right? Or DPC physicians understand that there's a market. Well, don't create products that nobody wants because nobody's going to give you money for it, right? Look at your community and assess the needs that the community have and fill that gap. And so that's kind of one of the big ways, or most recently ways anyway, that we've been able to leverage health equity, DPC, to help improve the health of the community.
No, that's great. I love that. And what I'm really hearing is that coming from these communities, coming from a place where there is a lot of distrust, what you're really doing here is breaking that negative feedback loop, right? And you're creating a virtuous cycle in there. And just that the story about the Black physicians list. Also, if anyone is interested, that is on the Harvest Health MD website. You can go to the resources section and the education link in there, and it is downloadable, it is free. Maybe some referrals for that network of folks for you. But the story that you were telling there, it's like, you made this list, and in part it was a little bit for you, but also to educate and spread awareness. And then the way that it built momentum for itself, right? And so there is a want and a need for all of this stuff, and it just takes someone, one person, anybody who has the commitment to step into that and help, right? And I think that this crowd, if no one else in healthcare is in a position to do that. Would you agree?
Absolutely. And that's one of the things that drew me towards DPC, because in training, I was a resident that took all the time with the patients. And, the attendants come in, let's go, Lawrence. You can't spend 15, 20 minutes, you need to be in and out. And it didn't fit what I would do. I was also the resident that the patient would come in 5, 10 times. Nobody could get them to do what they needed to do. Lawrence walks in, he spends 45 minutes, and now the whole clinic's backed up. But look, patient comes back, patient's on a better track now, right? And I think that resonates a lot with direct primary care physicians in terms of the type of quality of care that you want to provide for patients. And so when I looked at the DPC model, it was a model that was most poised to help me leverage that time and the ability to take care of patients and to address health equity in that way. And so that extra time that I have is spent with patients, but the extra time that I have is also spent in leadership positions, helping lead the nonprofit organization. It's also the extra time that I spent using lifestyle medicine and educating patients on natural ways that they can reverse diabetes and improve hypertension. Some of the things that you've heard of earlier, or yesterday rather. And so I think DPC is definitely poised with the positioning to make a dent in health equity. We just have to start thinking about what is it in equity, in the realm of equity, that's personal to us. Is it ageism? Is it ableism? Is it gender? Is it class? And then how does that inform your practice? So I'll give you one example for half the people in the room. Trauma-informed care and how we approach it. Women come into my practice, and part of my intake is, what trauma do you have? What kind of, one patient I'm thinking in particular, what kind of trauma? What do you mean? Whatever it means to you. I'll wait. Then you get the sexual trauma. You get the parental trauma and the issues and abuse, and you understand where the scope of anxiety and depression comes into their life. And now we get somewhere, because it's not just take this SSRI and come back in 4 to 6 weeks and let's see what it does. It's, okay, we need therapy. Okay, we're going to talk through some of these things and how you view the world, and then we're going to work on mindset and perspective and shifting the way that you view things so that you have a better approach to becoming healthier, right? Health is not just take the pill, it's also how you sleep, it's how you eat, it's how you approach life, it's if you have the social support, it's if you have, your relationship with substances and how, when you do alcohol, is it because you just enjoy it, or is it because you had a stressful day? And how much of that, depending on the person, is detrimental versus okay, right? And so you have to make that decision for yourself. But all of those things weigh into how we take care of patients. And so if you're not addressing those, I think DPC allows you the opportunity to address those wholly.
Yeah, thank you. And I'm glad that you brought up the time that DPC gives you to kind of focus on these efforts, because as I was reflecting on everything that we have heard over the last 2 days, the thing that I've come to understand is that in the traditional fee-for-service model, it's like, why are physicians not engaging in health equity work? And I think that in the traditional model, it's very easy to just say, I want to, but I'm just buried. I'm drowning under my own administrative burden and all these other things, and I don't have time, right? But in the DPC world, time is now on your side. You have time to wield, right? And so as I was thinking about Allison's keynote yesterday, I'm thinking now, for this crowd in here, right, we've had a lot of, we've had Black doctors up on this stage today, but there's still, in the crowd, not enough right? Even representing, at this conference, still not enough. And so, really, for the majority that is out there right now, I was thinking about Allison's keynote and thinking, is it fear, right? The fear of offending someone, the fear of doing something that is wrong? Is it the fear of not knowing how to engage with the community that's around you? I think that perhaps that it's worth challenging or worth reflecting on whether that is why, if you haven't engaged in the health equity work yet, that's something to consider, right? But leaning into Allison's message from yesterday, I wanted to kind of implore the folks in the room to lean into that being brave, the being earnest, and the being open to challenging your beliefs, because the DPC movement is all about that doctor-patient relationship. And ultimately, I think by being brave, being earnest, being open, that goes a long way towards building and rebuilding the trust in these communities that perhaps don't trust the healthcare system as it exists today. Anything you'd like to add before we wrap up?
No, I think those were very, very good points. We took an oath for the physicians in here to do no harm. Through my journey, I have some other pieces with health equity. I was in rural medicine for a little bit when I did locums to raise capital to start DPC. Came back and I had an experience where, a local physician who was a little bit less stringent about vaccinations passed. And then I started having people call my practice, moms telling me, I get that I don't vaccinate, but no physician in this town will see my kid. And my kid still gets sick and still needs health care. And so I've had some unique experiences that have changed how I view equity, which is why I think it's really important to harp again and to highlight addressing the needs that your community has, and then focusing on the particular spin that you can put on that. It's super important that we understand that doing no harm, as somebody mentioned before, means doing no financial harm. But it also means not being complicit or being absolved of the circumstances, that we understand that there are certain people, groups, Black, Asian, Native American, that they have worse health outcomes. Like, we know that, the data shows it. So knowing that and not doing anything about it is an issue for me, right? And so I hope it's an issue for you all.
Thank you so much, Dr. Lawrence. That is our call for everyone to go out and be defiant, right? This is the crowd to do it. Thank you so much for your time. I appreciate it. It's been an honor to share the stage with you.
Thanks for having me.